So we got lateral anatomy approach. The way of removing this, we may open the maxillary sinus also. This is the axis that we use to reach this tumor in the posterior nose. It is lateral anatomy approach or transpalatal. Lateral anatomy, you cut, and then you open the maxillary sinus, and then you reach the tumor, you remove it. It is after embolization, not vascular, so bleeding hopefully will not be great. Tumors of the nose, one of the commonest tumors is the inverted papilloma. From its name, you may think it is benign. It is benign histologically, but behaviorally it is invasive, bone destructive. It arises in the middle meatus, but it destroys the maxillary wall, it destroys the septum, may invade the orbit. So it should be removed completely, and it has the high rates of recurrence if you don't remove it completely. Surgery could be done endoscopic now, it is small. But if not, we do what's called medial maxillectomy. Medial maxillectomy is removal of the medial of the maxilla, including the small air cells, including the inferior turbinate and the middle turbinate. Okay? So it's called medial maxillectomy, but we remove the lateral nasal wall. In this condition, to be sure that we do not leave residual tumor because of the recurrence. We have to monitor the cavity that now the maxilla will be up, so you have to monitor the cavity by endoscopic endoscopy in the clinic for recurrence. Cancer of the nose, as you see, squamous cell carcinoma is the commonest by metaplasia. Patient is old patient with non-specific symptoms on one side. You may think it could be sinusitis, discharge, obstruction, pressure, maybe blood-stained discharge. Then you give antibiotics. It is a sinusitis, but it will not clear up by antibiotics. So you have to go and do endoscopy to detect this tumor early. This, we would like to shorten the delay before diagnosis because the orbit is near, the anterior fossa is near. So if you diagnose it late, you have intraorbital intracranial extension. So early diagnosis should be the aim. You take, you do CT, you do MRI, and then do biopsy. We prefer to take the biopsy after the radiological investigation to know that it is not very vascular when you take the biopsy. The treatment is surgery, dissection of the tumor. It could be with maxillectomy, total maxillectomy, or with orbital excenteration, or it could be craniofacial. And I'm talking about the tumor, if it is small, it could be by maxillectomy, total maxillectomy, not the medial maxillectomy like the papilloma, the total maxillectomy. If it extends to the orbit, orbital excenteration with the total maxillectomy. If it extends to the cranial fossa, we need to have the help of a neurosurgeon to do what's called the craniofacial resection. So the cranial part of the surgery and the facial part. So you remove the tumor as a whole from the skull base also. So it is the spectrum of surgery that we do, and later on you consider radiotherapy in this patient. It should be referred to specialized centers. It is a rare tumor, not very common. Corneal atresia, the congenital lesion, Dr. Marfani covered this. This child born with apnea at birth will develop cyanosis, and you do suction and put an airway, he will breathe through the airways. But once you remove it, you will have this cyclic apnea. Cyclic apnea. If you remove the airway, you will stop breathing. Because at birth, everybody is obligate nasal breather. He cannot open the mouth and breathe as we can do. So he will close the mouth and then stop breathing and get cyanosis. You put the airway, you improve the airway, the breathing. The color of the child will be pink, and he again, he may cry also. During crying, the breathing is in and out, so he will have good breathing. But once he stops crying and there's no airway, he will get cyanosis and is in suffocation. So you suspect this condition. It is bilateral then, because if it is unilateral, it may be missed at birth. Unilateral, the child will be breathing normal. It may be missed at birth, but bilateral will be immediately recognized at birth. It's an emergency. You have to fit an airway, And you can prove it by passing a catheter through the nose. It will not pass to the nasopharynx. If you put some drops of Listerine blue or any, it will not again appear in the oropharynx. In the CT, it is clear here, the atlantic plate, and the posterior nose is not, it is a funnel shape. So this funnel shape posterior nose, like here. The septum is here, the infiltrate plate. So you see the posterior nose is a form of a funnel with the quina atretic. So you need to do emergency perforation for the vagina to breathe. You fix a stent. Sometimes we do this emergency procedure, perforation, but later on we need to do drilling. Drilling not for big opening to make the quina pata. Could be done endoscopic, could be done with laser, could be done transpalatal to make this quina pata. Posterior endoscopy, this is nose could be examined by the speculum, by the mirror through the mouth, and by the endoscope. The common now is to use the endoscope. If I'd like to see the nasopharynx, I can go through the nose. I see panoramic view of the nasopharynx. But previously we used the mirror. We can still use it if there's no endoscope. This is what we see with the mirror. The mirror is transoral, the face is up behind soft palate, and you see the posterior of the septum, the quina is here. So with the quina you can see the turbinate, the biggest is inferior turbinate, very mulberry-like. The middle turbinate is superior turbinate. This is the roof of the nasopharynx. You can see that the adenoidal tissue here. It is not very big, but it's there's some residual adenoid tissue. That's why you see the Eustachian tube. Below here you see the soft palate, part of it. But this view is not by the mirror, it is by the scope. You see this ring, black around, it is endoscopic image. It is transoral with the endoscope to show you what we should expect to see by the mirror. Mirror will not give a clear as this. It will give very limited view and partial view. The right side, first, the left side, and the roof, but the endoscope will give this panoramic. This has a wide angle, the endoscope. So you see everything in one single photo. The lesion that you see in the nasopharynx, the adenoid is the commonest, but also polyp, and sequential polyp may be seen. Nasopharyngeal carcinoma in the fossa moral behind the Eustachian tube, behind it. So we see the nasopharyngeal carcinoma in the nasopharynx. Cyst may be seen. Here the commonest lesion in the nasopharynx is this is transnasal endoscope. So a child with adenoidal enlargement, snoring, is obstruction, is a discharge, mouth breathing, even sleep apnea. It's a very common condition. With the tonsil also may be big. May affect the middle ear by blocked second tube. So how to diagnose? From the history, from the clinical examination, you will not see the adenoids in the clinic by endoscopy or by oropharyngeal examination. So if you can do posterior endoscopy, you may see it. But if you have the flexible scope or the scope, you can go through the nose, back to the nasopharynx. You see medially here the septum, the Eustachian tube is here, the adenoidal tissue is here, the palate is here, the cavity, the nasopharynx, all this. This is transnasal with a flexible or rigid scope. It's not very blocking here. I can see some airway, and it's not very big adenoid, otherwise it will block the quina altogether. If it is too much. If you don't have the scope, you depend on the X-ray to confirm the diagnosis. In the X-ray lateral view, soft tissue film. Exposure is soft, not hard, because you'd like to see the soft tissue, the palate, and the adenoidal tissue. And you comment on the nasopharyngeal airway in between. Nasopharyngeal airway. The child, sometimes it's difficult to do the X-ray. Why? Because the child should be in neutral position, with the head not extended, not flexible. And the mouth should be closed also, not crying. Sometimes this could not be possible. But this is the idea, to have the child neutral position so that you do not overestimate the size of the adenoid with extension of the mouth. So the adenoid diagnosed by plain X-ray. The lesion that may be found on the nasopharynx is the nasopharyngeal carcinoma. The commonest is in the area behind the second tube. We call it fossa of molar. Later it will fill the nasopharynx, but early it will be in the fossa of molar. The patient is elderly patient. This tumor is called bimodal. It could also present in young adults, especially in endemic areas like China. They have it bimodal. Elderly people, which is the age of cancer, squamous cell carcinoma, and also in young people in China because of the smoking of foods and some dietary habits, so they may have this carcinogens. They have the patient, we are talking about the elderly patient presenting with lymph node below the angle of the mandible, or level 2, okay, deep to the sternocleidomastoid. You have a malignant lymph node. Any lymph node, painless, firm, growing in an adult patient, it is malignant until proven otherwise. You have to look for the primary. So taking the history about any problem in the nose, throat, ear, if there is infusion, connecting loss falling to the ear, this indicates that the second tube is blocked. You have to look in the fossa of the molar. Otherwise, you will look to other places, in the tonsillar fossa, in the posterior cell of the tongue, in the piriform sinus, in the thyroid, to detect the primary of this lymph node. Treatment of nasopharyngeal carcinoma, it is squamous cell carcinoma. There is some grading. Explain this. It is radiosensitive, especially the undifferentiated type, or what's called lymphoepithelioma. Lymphoepithelioma, very sensitive to radiotherapy. So we don't do surgery for the primary. For the primary tumor, we take only biopsy, and the patient will have full course of radiotherapy. For the lymph nodes, we do a radical neck dissection. So lymph node need neck dissection, but for the primary, it is radiotherapy. Surgery is only for biopsy. This patient will present with this lymph node, but later on he presents with a lot of symptoms: nasal obstruction, nasal bleeding, palatal paralysis, very severe headache, ear problem, paralysis of some nerves, cranial nerves, abduced nerve. You know this condition before CT and before MRI? It used to be diagnosed by clinical manifestations. If the patient has palatal paralysis and immediate infusion, you have to think of nasopharyngeal carcinoma. Okay? If the patient has abduced nerve paralysis, then the skull-based invasion and the foramen lacerum, all this based on thinking and anatomy. But now we can see with CT and MRI. And endoscopy, of course. Now the oropharynx. Very common condition, acute follicular tonsillitis, acute tonsillitis in general. The organism is group A beta streptococcus. The fever is there, the lymph node is there, the child has severe pain in the throat, halitosis, and you see the crypts full of pus. This is acute follicular tonsillitis, severe form of tonsillitis. You have to treat this patient if you can do culture or rapid antigen test to prove that this is group A, beta hemolytic streptococcus, so that you can have the rationale to give this long course of antibiotics for 7 to 10 days to eradicate the infection, to prevent complications, because it has a lot of complications. You have to also differentiate this from other causes of big tonsils. One of them is the infectious mononucleosis. Infectious mononucleosis is a viral disease. It may have a less acute course. It may take longer time for it to come. He has very big tonsils because the lymphoid tissue is hyperplastic in this patient, even the other lymph nodes. So he has generalized lymphadenopathy with very big tonsils, liver spleen. And why there's some exudate here? Is it bacterial or not? Bacterial is second infection. So you give antibiotics here. But to avoid ampicillin. Ampicillin is important to give rash, like the measles rash, morbilliform rash. We avoid a diffuse erythema if you give ampicillin. So we don't need to